Hello, everyone, and welcome back. Today we will be focusing on disruptive impulsive control and conduct disorders. And we've got 6 main types we're going to be discussing today, focusing primarily on the first 5. We're not going to get too deep into the weeds with other specified disorders, as these are typically used when a diagnosis is pretty unclear. The disorders we are going to cover include oppositional defiant disorder, intermittent explosive disorder, conduct disorder, the lesser known impulse control disorders of pyromania and kleptomania. So, one of the first questions we need to address when considering these disorders is how do we first assess for them? And while these disorders are less common than, say, for example, anxiety or depression, they're still observed, and particularly very much so in adolescence and young adulthood. There are a couple of assessments that you will come across that are used for this. So these will be something that you'll learn about in other lectures and in other courses, but we're just going to briefly touch upon these so that you will be familiar with them whenever you see them. So we've got the ASEBA, the Connors Revised, the Brown Attention Deficit Scale, the Woodcock-Johnson, the WISC, and the Level 1 Cross-Cutting Rated Symptom Measure questions 1 through 6. So these assessments you, again, will encounter whenever you're doing your practicum or your internship, especially if you're going to be working with adolescents being diagnosed with these disorders. And some of these disorders do share some commonalities, including similar responses to treatment. So we are going to discuss specific treatments for each disorder and some general trends. For instance, medications like lithium and antipsychotics are often used to treat this group of disorders. In terms of therapy, you'll often see CBT, cognitive behavioral therapy, parent training, parent education, which focuses on how to structure environments, manage child-parent interactions, and implement discipline. The PCIT, parent-child interaction therapy, is another approach that some may be familiar with already. And PCIT, therapists work directly with the parent on improving techniques during a session. Often the therapist is in an observation room with a one-way mirror, and they communicate with the parent through a microphone to provide real-time feedback and support on their interactions. Other therapeutic approaches may include behavior modification therapy, emotion regulation training, and social skills groups. Family therapy is particularly important when working with conduct or impulse control disorders, as these disorders often affect the entire family. Additionally, engaging teachers and other adults in the child's life is going to be very crucial, as interventions need to be implemented across different environments, especially when working with individuals who have developing brains. Let's talk about some risk factors associated with these disorders, to include abuse or neglect, such as having a parent with a mood or a substance use disorder, harsh or inconsistent discipline, lacking a caregiver supervision, poor relationships with parents or caregivers. In some cases, one parent may be absent, or the parent may not fit the traditional roles, such as when grandparents or foster parents act as guardians. These strained relationships can contribute to the development of these disorders. Other risk factors include family instability and parents with a history of ADHD or conduct problems. However, it's important to note that having a parent with these disorders does not automatically mean that the child will develop similar disorders. Rather, untreated mental health issues in parents can lead to dysfunction within the family and then increase the likelihood of mental health disorders in children. So, this often stems from inconsistent discipline and an inability to provide adequate supervision or abusive relationships. Financial instability in the family, often associated with poverty and parents experiencing marital troubles or divorce, are additional risk factors. It's important to clarify that while children of divorced families may face greater risk, this does not mean that divorce directly causes these disorders either. Again, very important to note. We are just discussing risk factors. These are not direct causes. This does not mean that X equals Y and that this is going to cause this. Additionally, exposure to violence, particularly domestic violence, can further exacerbate the risk factors. To better understand risk factors, think of risk factors for something like heart disease. For example, being overweight or not exercising or smoking is going to increase the likelihood of developing heart disease, but it does not automatically guarantee it. Similarly, these risk factors, when combined with genetic predisposition can kind of create a perfect storm for developing these types of conduct and impulse control disorders. Okay, so whenever we examine these disorders, it's important to differentiate between them. So we've got disruptive mood dysregulation disorder, DMDD. Then in the middle, we've got oppositional defiant disorder, ODD. And then on the other side of the screen, we've got intermittent explosive disorder, IED. These are often misdiagnosed and confused with one another in the field. Disruptive mood dysregulation disorder often involves irritability or anger, sometimes manifesting as verbal or physical rage, occurring 2 to 3 times per week for the first 12 months. The onset typically occurs between ages 6 and 10 and can extend into adolescence. DMDD is characterized by a inability to regulate emotions rather than defiance or extreme aggression. Now, let's talk about intermittent explosive disorder. This is marked by verbal aggression, assaults, destructive outbursts, but the individual with IED often feels remorseful afterwards. And then there in the middle, we've got ODD, oppositional defiant disorder, and that involves persistent verbal aggression and defiance lasting more than 6 months, with behaviors that are more severe and chronic. So, with DMDD, the irritability and anger are more persistent and stem from a lack of emotion regulation rather than from intentional defiance or extreme outburst. DMDD tends to be more cyclic and predictable in nature. As the child grows and their brain develops, many will eventually gain better emotion regulation skills, which can result in a decrease of symptoms over time. However, when left untreated, DMDD can increase the risk of developing other disorders, such as ODD. While they are not directly linked, whenever the child doesn't have the appropriate coping skills or doesn't get the help that they need, one could potentially, possibly lead to the other. It's crucial to understand these differences, particularly in children and adolescents, as misdiagnoses are common due to the lack of understanding. Recognizing these distinctions early can lead to more accurate evidence-based treatment, including the use of medications, which may be more effective for mood dysregulation disorders than for ODD or other conduct and impulsive disorders. So let's switch and talk more about intermittent explosive disorder, IED. This diagnosis is given when an individual experiences recurrent outbursts demonstrating an inability to control aggressive impulses. These outbursts are not premeditated, meaning the person is not intentionally seeking revenge or targeting someone. They can affect both children, adolescents, and adults. And the individual must be at least 6 years of age or older. To meet the criteria for IED, there must be verbal aggression occurring at least twice a week for a period of over 3 months. Additionally, there must be physical outbursts that cause damage or involve assaulting animals or people at least 3 times in 1 year. This distinguishes IED from other disorders such as DMDD, as it involves direct physical aggression and damage rather than ongoing irritability or anger. So, what should we consider when evaluating these disorders? Well, brain chemistry plays a very significant role. Research has shown varying levels of serotonin may contribute to the development of IED, which is evident in studies of individuals diagnosed with this condition. Additionally, higher scores on the ACEs, the Adverse Childhood Experiences Scale, is associated with the increased likelihood of developing IED. This disorder is most commonly diagnosed between adolescence and the age of 40. As highlighted in one of our videos this week, there is a notable difference between childhood and adult experiences. Those diagnosed with IED often have a history of other mental health conditions, such as ADHD, antisocial personality disorder, and borderline personality disorder. Moreover, nearly 82% of individuals with IED also experience depression, anxiety, substance use disorders, indicating a high rate of co-occurrence with other mental health issues. So now that we understand the basics of IED, let's talk about treatment. Treatment typically involves both medication and therapy. We're going to dive deeper into specific medications later, but commonly used approaches are antipsychotics, including some others. And as for therapeutic methods, there are several for managing IED, including cognitive behavioral therapy, CBT, trauma-informed CBT, group therapy, neurocounseling, and techniques like mindfulness and exploring the brain-body connection are very valuable. One important aspect of therapy is the concept of neurons that fire together wire together. This is something that you will often hear. Our goal is to lengthen the reaction time to anger, giving the client more time to think and implement coping strategies before reacting impulsively. Additionally, acceptance-based approaches can be beneficial in helping clients accept themselves while also addressing areas for growth and change. And then there at the bottom, you'll see DBT as another option. So what kind of coping strategies are we focusing on? Some key techniques include relaxation exercises, cognitive restructuring, which involves rethinking and changing thought patterns, improving communication. Often anger arises from difficulty in expressing emotions, so enhancing communication can be vital. Additionally, learning to modify environments to reduce stress in triggering situations is important. And finally, it's essential to address substance use, avoiding alcohol and recreational drugs, as these can make anger or impulsivity worse or just make the individual have kind of a short temper. Okay, let's transition into ODD. To start with, the diagnosis of ODD, the behavior must be present for at least 6 months, and it must include patterns of negativity, defiance, disobedience, and hostility. The DSM-5 provides more specific details, including cultural considerations, the prevalence in the general population, and the comorbidity aspects. It's important to note that about 50% of individuals diagnosed with ODD also have ADHD. So what might that look like in practice? What might a parent or a child or a teacher report? Or what might you observe in the home or the school or the community setting? Common behaviors include frequent temper tantrums, argumentative interactions with adults or authority figures, refusing to comply with requests, deliberately annoying others. This isn't simply sibling rivalry. We're talking about a child who finds joy in provoking others. Additional signs include blaming others for their misbehavior, being touchy and easily annoyed, exhibiting irritability and anger, showing resentment towards close individuals, and demonstrating spiteful or vindictive behavior along with aggressiveness towards their peers. Okay, now we've got a chart here looking at ODD. This can impact many different areas of a client's life, including their relationships, behavior, and overall emotional well-being, and how that shapes their everyday life. So, in relationships, we often see disregard for rules and authority, hostility towards peers, and strained relationships. There may also be a history of learning difficulties. Anger is often considered a secondary emotion, masking underlying feelings of hurt, poor attachment, or fear. For example, there may be resentment towards caregivers, especially when combined with a high ACEs score. Remember, ACEs stands for Adverse Childhood Experiences Scale. Poor parenting practices. Children may seek to provoke reactions using anger as a learned response. Inappropriate language, including swearing, can also be very common. Anger in these cases is often not provoked and becomes an ingrained emotional response over time, contributing to poor coping mechanisms and negatively affecting the brain's development. This poor attachment also means that the individual may not feel the emotional consequences of their actions. So, in terms of behavior, kids with ODD may aggravate others, fail to consider consequences, avoid responsibility, shift blame onto others. They may take small things and kind of blow them out of proportion, leading to discomfort in those interactions and observing others observing their behavior. As a therapist, it's important to remember that children and adolescents struggle with these disorders and they may not seek help themselves. Often it's a family member or a caregiver who are making the effort to bring the child into therapy, and reports may come from schools or frustrated family members. So, understanding this dynamic can help in framing the situation for parents and caregivers, offering them hope and reassurance that the change is possible and helping them understand these behaviors are not their fault. Now let's take a look at the brain. This helps to kind of understand research from another perspective. So this here is showing an adolescent brain with ODD. In this study, the green areas represent parts of the brain showing overactivity when compared to a control group. And the most notable areas affected are the globus pallidus and the amygdala. So you can see that and all the way on the left is the globus pallidus, and then if we move one over, there's the amygdala. So you can see the green areas are the overactivity. The amygdala, you can think of it as like the brain's smoke alarm system. It is responsible for the brain's fight or flight response, and it causes heightened states leading to that dominant fight response in this particular disorder. So the important question is there hope? Whenever clients come to see us, this is usually their main concern. What can we do to help them? Well, when it comes to treatment, the gold standard is long-term multimodal approach that spans the lifespan, and it addresses developmental needs, considers the person's environment. This includes everything from the individual to the home to the school. Consistency is key, and interventions should be comprehensive. Family therapy, especially addressing poor attachment and parenting skills, is crucial. Engaging teachers and other adults in the child's life is also going to be pivotal. We talked about this earlier. PCIT, parent-child interaction therapy, will come up repeatedly throughout this lecture. Supportive therapy may also include working alongside the individual to address co-occurring issues like learning disabilities, anxiety, depression, or substance use. Problem-solving skills are important, as often anger is going to arise from irritability to navigate problems, triggering the fight or flight response, and this leads to a cycle of constant tension and aggression. CBT, cognitive behavioral therapy, behavior modification, emotion regulation, and social skills training, again, will also be essential in helping individuals, especially kids and adolescents with ODD, develop those coping skills that they lack. So without these tools, everything becomes a conflict, and aggression tends to be the primary response. Let's move into discussing conduct disorder, which can potentially develop from ODD. As the severity increases, the behaviors become more extreme. In conduct disorder, we see more pronounced aggressive behavior, deceitfulness, destructiveness, and a disregard for rules. These behaviors represent a progression from what we observed in ODD. So I want you to keep in mind the continuum we've been discussing as we delve into more intense characteristics of conduct disorder. So, to receive a diagnosis of conduct disorder, an individual must exhibit at least 3 of the following behaviors in the last 12 months, with at least 1 occurring in the past 6 months. These behaviors are much more severe compared to those in oppositional defiant disorder, and they include aggression towards people and animals, intimidation, physical altercations, use of dangerous weapons, cruelty to people or animals, stealing directly from victims through confrontation, for example, carjacking, forced sexual activity, property destruction, including arson. This will be different from pyromania, deceitfulness, theft, breaking and entering, manipulation of others, and serious rule violations such as running away from home more than twice. These behaviors typically begin before the age 13. Additionally, it's important to rule out antisocial personality disorder, especially in older individuals, as the behaviors in conduct disorder are more extreme. Okay, so when we're discussing physiology and neurology of conduct disorder, we observe the brains of individuals with this disorder compared to control participants. And notably, the individuals with conduct disorder exhibit much higher concentrations of brain activity in areas like the amygdala, like we talked about before. That's going to be the kind of the smoke alarm of the brain, and the prefrontal cortex. So this heightened activity reflects a more reactive response, unlike what we see in the control group. And this reinforces the idea that conduct disorder is not a choice, but rather a condition that we can treat. The connection between the mind, body, and brain is a very appropriate intervention, and the brain can change over time, offering hope for recovery and a different future. When working with conduct disorders, it's important that we note that it's often comorbid, again, with ADHD, as well as other disorders we've discussed, such as generalized anxiety disorder, major depressive disorder, are very commonly seen in folks with conduct. Additionally, it's crucial to rule out antisocial personality disorder, particularly in individuals over the age of 18 and in the most severe cases of conduct disorder. All right, when we're considering treatment, combining therapy and medications tends to be a very effective approach. Medications commonly used include lithium and antipsychotics such as Haldol. We've discussed this in a few lectures, they keep coming up. Therapy-based skills, especially in home environments, are not conducive to therapeutic process. And in such cases, school and treatment facilities or community programs can provide additional support. So it kind of has to be across various different areas or environments in the one's life to be the most effective. Behavioral therapy, including CBT, is often utilized. Juvenile programs are significant as children with conduct disorder may be placed in facilities like schools for troubled youth, where they receive consistent therapy. Some may attend specialized private schools, such as um, some that you may be familiar with, where they receive treatment because they struggle to function in mainstream school environments. For more intense interventions, there are wilderness programs. A lot of these are located in places like Blue Ridge Mountains or Utah, and they offer adventure-based learning and self-reliance with the added benefit of intensive treatment in a distraction-free environment. Residential treatment is another option where children may be placed for their safety or for parental uh, respite. Parent skill training is often recommended as part of the treatment plan. In this overview, we discussed three key aspects of conduct disorder. Three types of disorders: conduct, impulsive, and disruptive disorders. Now, these are named for their connection to impulse control as they are highly disruptive to functioning, both socially and within societal norms. So consider the continuum from all of these various different disorders and take note of each of these and how do they contrast. It's essential to think about the whole client and not just the behavior, because this includes examining the brain, the family dynamics, the school environment, and asking what else is going on. So when clients have these disorders, they could potentially be very lovable, yet appear unlikable to teachers and caregivers and therapists and even legal authorities. They may not receive much positive attention. Often untreated ADHD progresses into other disorders as these children can accumulate 20 to 30,000 negative messages every 6 to 12 months, constantly being told you're doing it wrong, you're not good enough, you're bad. This creates a negative feedback loop, particularly when parents, educators, and caregivers are not educated on the challenges involved with these disorders. So, this sets up a system where this constant negative reinforcement compounds the issue and often adding to more adverse childhood experiences that are tied to trauma and long term health outcomes. So, this kind of creates a perfect storm where the disruptive behavior is a symptom of deeper problems. While we focus on treating the behavior, it's crucial to recognize that these children, adolescents, and adults need support. They are capable of improvement, and with effort, we can rewire the brain. However, it requires a willingness from both the provider and the client. Okay, now we've got two more disorders, and these are true impulse disorders: kleptomania and pyromania. These disorders often are pique a lot of curiosity and interest. They are very much more rare compared to the disorders that we've just spoken about, particularly in private practice or outpatient settings. However, they do appear occasionally, and it's important to understand what you may encounter along with key considerations regarding the etiology, symptoms, and treatment. So we're briefly going to explore these, starting with kleptomania. When diagnosing kleptomania, it's important to note that unlike typical shoplifters, individuals with kleptomania do not steal out of desire for material gain. The act of stealing is not driven by a need for the items, but rather an overwhelming urge or kind of even a compulsion, similar to the behavior seen in addiction. Episodes of stealing are spontaneous without planning or collaboration, and no one pressures the individual to commit theft. People with kleptomania often steal from public places such as stores or supermarkets, and in some cases, they may steal from friends, coworkers, or even acquaintances. The stolen items typically hold no value to the person, and they can easily afford to buy them. Core issue lies in the impulse itself and the inability to control it. Afterwards, the individual often experiences feelings of shame and guilt. This behavior is tied to the dopamine cycle in the brain, and the stolen items are often hidden away or secretly returned. And these urges to steal can fluctuate over time, coming and going throughout the person's life. Now, excuse me. Okay. The cause of kleptomania are linked to several factors, including brain chemistry. One key element is the neurotransmitter serotonin, which helps regulate mood and emotion. Individuals with kleptomania often experience imbalances in serotonin, which can contribute to the disorder. Stealing may trigger a release of dopamine, leading to that pleasurable high that reinforces the behavior through the dopamine loop, where individuals feel good and seek to repeat that experience so they can have more good feelings, more pleasurable feelings. However, this is followed by guilt and shame, creating this very complex cycle of behavior. The brain's opioid system plays a role in regulating urges. And since the opioid system is closely connected to the dopamine and the serotonin system, an imbalance in these neurotransmitters makes it even more difficult for an individual to resist this overwhelming urge to steal. Kleptomania is diagnosed when there is a recurrent inability to resist the urge to steal. Individuals often experience a growing sense of tension right before the act of theft. The impulse driving that behavior, the act of stealing provides a sense of pleasure, gratification, or relief. The stealing is not motivated by anger or a reaction to a delusion or a hallucination. Additionally, the behavior cannot be explained by conduct disorder, a manic episode, or antisocial personality disorder. Again, there's hope for individuals with kleptomania. As an effective treatment options, they are available. Most successful approaches typically combine therapy with medication. Therapy options include techniques such as covert sensitization, aversion therapy, systematic desensitization. These methods may not be commonly discussed in general therapy courses because they're more specialized. So let's talk about each of them. Covert sensitization involves visualizing the act of stealing and then imagining negative consequences, helping to strengthen the connection between the emotional brain, so the limbic system, and the logical brain, meaning the prefrontal cortex, ultimately reducing that impulsivity to steal. Aversion therapy may include mildly uncomfortable techniques like holding one's breath, snapping a rubber band, or smelling something really unpleasant to kind of avoid that urge to steal. And so, whenever that urge does arise, doing that unpleasant thing to create an association between the urge to steal and something unpleasant, like the snapping of the rubber band or smelling something really awful. Systematic desensitization utilizes relaxation techniques where individuals imagine themselves resisting the urge to steal, gradually training the brain to manage the impulse in real life situations. And then, with regard to medications, we're going to use things that we normally would to treat addictive behaviors. And this may look like naltrexone. This helps to reduce cravings, and it can be helpful alongside with SSRIs, selective serotonin reuptake inhibitors, also known as antidepressant medications. And these help address the serotonin dopamine imbalances seen in kleptomania. Let's move to our last disorder, pyromania. While it may seem very similar to kleptomania, there are key differences. Pyromania is often confused with arson, and they are not the same. Arson refers to a criminal act of setting fires, whereas pyromania is a psychiatric disorder characterized by a compulsive urge to start fires. Pyromania is extremely rare and under-researched, with its true prevalence being very difficult to determine. Some studies suggest 1 to 3% of individuals in inpatient treatment may have been assessed or diagnosed with pyromania, but less than 1% of the general population is affected. Individuals diagnosed with pyromania are typically male, with the condition often manifesting during adolescence. Additionally, learning disabilities and social skill deficits are frequently observed in those with this disorder. To meet criteria for pyromania, an individual must intentionally set fires on more than one occasion. Simply setting fire does not qualify for the diagnosis. The person must experience a buildup of tension or an irresistible urge before starting the fire. Showing a compulsive attraction to fire and fire-related items, such as gasoline or matches. Additionally, the individual must derive pleasure or relief from the act of setting the fire. These behaviors cannot be better explained by other conditions such as conduct disorder, a manic episode, or antisocial personality disorder. A diagnosis of pyromania is only appropriate if the individual is not setting fires for personal gain, such as financial reasons, like burning down a home for insurance purposes, or for ideological reasons, like domestic terrorism. The behavior is not triggered by anger or vengeance or the desire to cover up another crime, nor can it be in response to delusions or hallucinations or impaired judgment because of intoxication. All right. Now we've discussed the etiology and diagnostic criteria. Let's talk about treatment for pyromania. This treatment approach is similar to that of kleptomania, as it involves poor impulse control and compulsions. So, in the case of pyromania, inpatient treatment is more commonly required. The dangerous nature of pyromania can put people's lives at significant risk, which often necessitates initial treatment in a controlled setting. Fire safety, prevention, and caregiver training are especially important, particularly for those under the age of 18. It's crucial to ensure that environments, whether that's home, school, or elsewhere, are safe, as uncontrolled urges can lead to harm or even death. For example, someone may mistakenly believe that an abandoned building is a safe place to satisfy their compulsion and may be unaware that others are actually present in what appears to be an abandoned building. To reduce the risk of property damage or loss of life, safety training and prevention measures are crucial. This may include installing smoke alarms or smoke detectors, ensuring someone is always present with the individual during early treatment, and limiting access to fire starting materials. Given the high risk to both the person and others, treatment for pyromania may require more intense monitoring and intervention. That's all we've got for this lecture. Thanks for your time and attention, and I'll see you in the next one.